Hello, everyone. I'm André Gomes from Brazil, and today I'd like to share with you some thoughts on epiretinal membrane. But first, I would like to thank the Argentinian Society of Ophthalmology for this very, very kind invitation. It's a pleasure for me to participate, and I wish you all a very successful meeting. And more specifically, I'd like to talk about epiretinal membrane with good vision. Why? Because we still have many questions pending regarding the specific time to advocate surgery. These are my financial disclosures. So when it comes to symptoms, we all know that epiretinal membrane, the idiopathic version, can be asymptomatic for decades. The patients, they can develop visual loss. There are some a specific type of these patients where the progression happens quite fast. With or without the metamorphopsia. Metamorphopsia is one of the main symptoms, and that causes a lot of trouble to the patients per se. When it comes to the surgical treatment, we all know that the prediction of the visual outcome is essential for patients' counseling and for weighing the risks against the benefits of the surgery, of the procedure. Therefore, surgical indication is very important. And when it comes to surgical indication for idiopathic epiretinal membrane, as far as correct timing, it has not, yet been standardized. And therefore, clinical outcomes, they vary quite a lot. How about natural history? We all know that the patients, they may remain with good vision acuity for decades. But there is a specific group of patients, they develop worsening very, very, quickly. So therefore, in patients that remain with good vision, surgery with the patient with visual acuity greater than 20/30, especially those without any metamorphopsia, surgery may be postponed. In that case, observation only might be the best option. But how about those patients with vision 20/30 and worse? Do we still wait, especially because we, up until recent years, we used to wait until the vision got worse than 20/60 or 20/70. But with the literature that we've gathered lately, should we operate earlier? How about ILM peeling? It's really a must-do. And why is that there are some patients, they do not regain vision. Even though they gain some vision, the vision don't get 20/20, 20/25 or so. So what do we know? We know that we have been operating for decades, and final visual acuity in some cases of epiretinal membrane rarely go back to 20/20. We even discussed with some of the fellows, with the fellows that even patients with macular holes sometimes, they go more easily back to 20/20 than patients with the epiretinal membrane. We evolved quite a lot lately, especially the late decades. With the valve trocars, with the new instrumentation, new machinery, with the heads-up display. Now we have better fluidics, and we tend to cause less new breaks, especially because with the trocars going in and out of the eye, so we don't cause any dragging or any traction at the vitreous base. And we've had them for over 2 decades. We have the eyes to facilitate the procedure, the peeling maneuver per se. Some authors, they have described that if we have severe foveal dystopia, which means that we have a lot of traction, we may lead to capillary leakage and possible damage to the RPE and photoreceptors. So what does that mean? So we have damage to the outer retina, some structural damage to the retina, and that may damage the final results. Same authors say that the extent of tractional dystopia correlates with decreased visual acuity. So too much traction, worse visual acuity. Cases with extreme degrees of foveal dystopia may benefit from early intervention to prevent damage to the retina, structural damage to the retina that cannot be recovered from the peeling procedure. When it comes to ILM peeling, should we peel or should we not peel the ILM? We know that based on the literature that the recurrence rate can be up to 20%. What happens is the fact that if you peel the epiretinal membrane only, we may leave some cells behind. in up to 20% of the cases, some glial cells, hyelocytes, myofibroblasts. So we leave the cells behind. So we leave the scaffolding for cellular proliferation. So we have recurrence of the epiretinal membrane. And both recurrence and incomplete recovery of the visual acuity can be due to incomplete removal of the epiretinal membrane. So we know that if you peel the ILM, so you're gonna end up peeling the epiretinal membrane completely. But we have to be careful. So it may damage the retina in some situations if you decide to go for the ILM peeling too. Some papers, especially this here by Schirling, they did some systematic review of the literature, and they tried to come up with some predictors, some biomarkers, for epiretinal membrane surgery. They looked at preoperative visual acuity, metamorphopsia, central foveal thickness, the thickness of separate layers, external limiting membrane integrity, the outer retina, cone outer segment tips integrity, fundus autofluorescence, and also electroretinograms. So this is a standard procedure for that we use to remove the epiretinal membrane. So here, first pinch, try to remove without any dye. One could also use some dye to do some negative spilling and negative staining when you use the brilliant blue. But here, after that initial pinching maneuver, so the dye can penetrate underneath the epiretinal membrane and dye and get it dyed inside out. So first we peel the epiretinal membrane per se, as you see here, being very gentle, try not to create any extra damage to the retina. And after that, you go after the ILM. It becomes very easy to peel the ILM after the use of dye when you remove the epiretinal membrane. You usually see the flap looking at you. So you go there and grasp that flap, and you do a very oriented peeling the extent that you decide. But again, one should be very careful because there are visible damage that you see sometimes when you pinch the retina too aggressively, you cause some hemorrhages, and also some maybe invisible damage if you exert too much traction during this maneuver. So Schirling and co-workers, they end up saying and finding that the predictors that may have a final impact on the outcome of those patients are the pre-op visual acuity. They're very important on the final absolute visual acuity, not the mean change. We all know that usually if you correctly peel an epiretinal membrane, the visual acuity usually improves 2 to 3 lines. But sometimes it doesn't go back to 2030, 2025, or 2020. Pre-op visual acuity, when it's better, it's going to give you a final absolute visual acuity that is better. Also, the importance of the integrity of the outer retina. Without the integrity, there is no good final visual acuity. And also the severity of metamorphopsia. And if you look at all those predictors, you're going to see that they are all related to the duration of the symptoms, which means that if you wait too long, you're going to end up with worse predictors and therefore a worse final outcome. But there is also problems with the ILM peeling, because if you're not careful enough, you can develop some toxicity due to the use of the dyes. You can damage the Miller cells. You can cause also some paracentral retinal holes if you're too aggressive and you're not you don't gather experience a lot yet. You can cause dissociated optic nerve fiber layer. And also, if you keep the probe, the light pipe, too close to the retina, you may end up with some phototoxicity, at the retina, which means the phototoxic damage to the macula, which is going to cause a worse final visual acuity. So this is an example of a bad result. So this is a patient in which the surgery went totally well without any extra damage to the retina. You see some whitish area like temporal to the fovea, which is some residual crystals of a triancinolone that we left behind. And you see that during the first week, the patient developed some swollen retina. And the end of the first month, the retina became a bit atrophic, and it kept that way for good. So the patient never recovered, ended up with 2400, which is a vision worse than day zero. And this is maybe a combination of a toxicity due to the procedure and the dye. And so that's why, so you have to be very careful, very gentle, and select the patients correctly for the procedure. So what should we do then to maximize our outcome? We should consider operating earlier. In those patients, of course, with vision 20/30 or better, especially when you don't have any metamophobia, you can observe. But patients worse than that, you should consider operating earlier. There is enough literature that you can look up to and realize that if you wait too long, you're not offering the best to your patients. Avoid long periods of preoperative leakage that might generate damage, which is anatomic damage, structural damage to the outer retina especially. Try not to leave tissue behind, which means sometimes, especially in those cases with thicker and older type of membranes, when you have to peel the ILM membrane. To do so, try to minimize tissue stretching preoperatively, not waiting very long, and during the surgery. Be careful during the peeling procedure, because there are some visible damage and maybe some invisible damage too that can lead to a worse outcome. Watch out for toxicity from the light pipe and from the dyes, especially for the younger surgeons. Try to control your light pipe. Do not stick that light pipe too close to the retina. If you are seeing the light pipe through your microscope or through any system that you're using, maybe you're too close to the retina. So you pull that out, or pull that close to the trocar, so you don't end up with some phototoxicity to the area where you're peeling. And how about the ILM? Maybe ILM removal is not a thing that you should offer in every single situation, especially in those cases with very good initial visual acuity. But of course, if the patient, after the removal of the epiretinal membrane, you look through the microscope, or through the head-up system, or maybe if you have a intraoperative OCT, and if you see there is still some persistent wrinkling of the retina that may cause some, a worse outcome, or maybe some maintenance of your metamorphopsia, you should go ahead and peel the ILM. But if you decide to do so, please be very gentle. So if I could come up then to end this brief discussion, if I could come up with some few take-home messages, I would say that even though visual acuity in patients with epiretinal membrane may decrease slowly, surgery usually improves final visual acuity. But improvement of final acuity when it comes to mean change might not be enough nowadays. What really counts is the absolute final visual acuity. So if you look at the literature, you're going to see that there is enough evidence that waiting too long may favor a worse overall outcome. Therefore, one should consider advocating surgery earlier these days in order to end up with a better outcome, a happier patient, and a happier surgeon. Thank you very much.